Okay, so thank you everybody for joining us today for this webinar entitled Evidence for Nutritional Intervention in Hip Fracture and Issues for Clinical Practice. Next slide, please. So this is the first in a series of free seminars brought to you by the Hip Fracture Recovery Research Special Interest Group of the Fragility Fracture Network. Today, we're really excited to have three fantastic speakers. So we've got Professor Alison Avenell, Dr. Christine Baldwin and Masar Dubas, who are willing to take the time to contribute their expertise in the field of hip fracture and nutrition today. Next slide, please. So before we begin, I'll quickly outline the plan for the seminar. So we've got three 20-minute talks from our speakers. This will be followed by a Q&A session based on the presentations. So please type your questions in the question section to the right of your screen. If you see a question that you'd like answered, please give this question a thumbs up and we'll prioritise question with the most thumbs up to be answered first. Questions will be left to a 30-minute Q&A session at the end, but if there's a point that you require clarification on from an individual speaker's presentation, please do ask this and we'll do our best to answer this question at the end of that individual talk. So we'll then close off the session with details of how to join our special interest group for future information on future free webinars, and also a brief overview of other Fragility Fracture Network initiatives related to nutrition. So without further ado, I have the greatest pleasure in introducing our first speaker, Alison, who's the Clinical Chair of Health Services Research at the University of Aberdeen. She's an honorary consultant in clinical biochemistry and and with three other consultants leads the multidisciplinary nutrition team at Aberdeen Royal Infirmary. So Professor Avenell has published several Cochrane reviews on nutritional management, and we're delighted to welcome her to speak today. So without further ado, I'll pass you over to Alison.
Thank you very much. I'm just going to share my screen, if you just hold on a minute. Sorry, we had one or two issues before we got started, so I'm just bringing my slides up. There we go. Sorry to keep you waiting. Thank you very much for asking us to do this presentation today. I'm going to kick off with talking about the evidence base in this area as I see it. First of all, I should say that none of us have any conflict of interest to declare, and we don't have any links to the Fragility Fracture Network or its information sharing. So these are our personal viewpoints. So some general discussion about definitions. What do we mean by malnutrition? Officially, malnutrition is a state of nutrition in which there is a deficiency or an excess or imbalance of energy, protein and other nutrients, causing measurable adverse effects on tissue, body form, function and clinical outcome. So malnutrition, which is what people generally use as the term, encompasses both undernutrition and overnutrition. And today we're really going to focus on undernutrition, but you'll have to forgive us if we occasionally slip our words and use malnutrition instead. But we're really talking about undernutrition. What about the typical patient with a hip fracture? If we look at this overview of evidence around presence of undernutrition in people with hip fracture, taken from 12 international studies, we see that around about a fifth of patients are undernourished and around 35% at risk of undernutrition. So undernutrition is common in the hip fracture population, which I don't suppose is probably any surprise to all of you. And there are various nutrition risk scoring systems which are quick and easy to administer. And generally, these show that these predict poor recovery from hip fracture. But the important thing to know about these nutrition risk scoring systems is that they are also markers of underlying disease states, so that older people who have undernutrition also have many other comorbidities, and it may be these rather than the undernutrition which are associated with poorer outcomes after hip fracture. In the big study of prediction of poor recovery from hip fracture, with over 500,000 patients with hip fracture, 8 main predictors were associated with in-hospital mortality, of which a history of weight loss was one. But as you can see, common predictors were also age and sex, and presence of heart failure and pulmonary disease, kidney disease, and also problems with fluid and electrolyte. And we know that older people with hip fracture are very likely to have a low body mass index, but one shouldn't also forget that older people also may be overweight or even obese. But if they lose weight over a period of several months, that also may be an important predictor of being undernourished. The typical patient with a hip fracture is more likely to visit family doctors, more likely to be on more medications, have a history of falls, more contacts with health services, and actually could probably have been identified as being at risk of a fracture before they ever had the fracture. What are the causes of undernutrition in older people? There are many problems that may rise in people who are at risk. So physical problems, needing help to go shopping or with their cooking, financial issues, mental health problems, and also institutional issues for people who may need additional support with eating or actually serving their food, all sorts of issues. And older people face many challenges, a huge long list of them. And it's not surprising that they struggle sometimes with nutrition as a consequence. So what are these consequences of undernutrition? We know that weight loss is associated with muscle wasting and loss of strength. This will impact on mobility and ability to self-care, make people at increased risk of falls, and muscle wasting and loss in the chest wall will increase the risk of chest infections. Undernutrition is associated with impaired immune function and poor recovery from existing infections. It also impairs wound healing and may contribute to the development of pressure sores. And all of these things may impair the recovery from surgery, leading to longer rehabilitation and the ability to not be able to care for themselves at home any longer. One of the things people don't perhaps realise that if you are undernutrition, this in itself may lead to a state of apathy and depression. And all of us who work on nutrition teams are well aware of undernourished people who are really lethargic, uninterested in life. And if you give them food, after 2 and 3 days, they actually tremendously improve and become mentally alert. So just because somebody is apathetic and depressed, do not consider that you should not bother to intervene with nutrition. Impairment of temporal regulation may contribute to hypothermia, particularly in older people who have fallen and lain for a long time with their hip fracture. And also undernutrition impairs the ability to regulate salt and water balance, which may contribute also to confusion. And all of these things contribute to poorer clinical outcomes after any disease state, may increase the risk of morbidity, poor wound healing, more infections, more complications, longer convalescence, longer stay in hospital, more contacts with health services afterwards, more likely to be readmitted to hospital. And these can decrease the quality of life and increase the cost of care for older people. So there are many associations between undernutrition and poorer outcomes from hip fracture and other fractures, but we don't know actually if improving nutritional state in people who have been identified as at risk actually can influence the outcomes after hip fracture and improve those outcomes. What about screening for people at risk? As I mentioned, there are various screening tools. They usually take less than 5 minutes to administer. And potentially people who are admitted to hospital should be screened for nutrition risk when they come in the door. Certainly in our area of the health service, the guidance is that everybody who is admitted to the hospital should be screened with the malnutrition universal screening tool. We know that even if you screen people with hip fracture when they come into hospital, almost all of them will lose weight whilst they are in hospital, unless they have issues with fluid balance, and therefore all are potentially at risk from a hip fracture. What approaches do we have to improving nutritional state? We have food-based approaches, so you can increase the portion size or the amount of food that's given. You can fortify the food to increase its energy and protein content so that the nutrition is more energy dense. And you can provide snacks between meals, so help people with additional cakes, drinks, puddings, and the like. And there are also oral nutritional supplements, or ONS, and these typically are around 200 mils or so and provide about 200 to 300 calories, 15 to 20 grams of proteins, and have various styles, both sweet and savoury. So let me talk now also about my Cochrane review, which was last undertaken in 2016 and has had many updates. But as far as I know, the evidence really hasn't changed since we last published our most recent update. Now, the bottom line for mortality. In this Cochrane review, we looked specifically at whether oral nutritional supplementation with mainly oral nutritional supplements, such as those SIP feeds that I mentioned, had any impact on mortality. And what you can see is that, first of all, we have 15 trials which provide data, but actually they're very small trials. And even though we have 15 trials, the data only comes from around 1,000 participants. And actually the quality of those trials is low quality. Overall, we see that ONS has no statistically significant effect on mortality. The risk ratio has very wide confidence intervals, but the evidence would favour supplementation, but the evidence is very unreliable. If we look at evidence for the effect of oral nutritional supplements on complications, we see that there are even fewer trials and a smaller number of participants. And by complications after hip fracture, I mean things such as pressure sores, infections, deep venous thrombosis, pulmonary embolism, episodes of confusion. And here we have low quality evidence again, but the evidence would suggest that oral nutritional supplementation may reduce the risk of complications after hip fracture. But it is low quality evidence and the confidence intervals are wide. We have really very little evidence of the adverse effects of these supplements. Some trials have looked at whether these supplements might cause vomiting or diarrhea. Again, only 3 trials really presented data. Most trials didn't even report data, may not even have looked at data. And we can't be clear that there is an adverse effect from these interventions. So is there wider evidence that might suggest that oral nutritional supplementation might help frail elder people who are at risk of malnutrition? And this is a Cochrane review that I also worked on. It's old now, in 2009, but as far as I'm aware, there's been no real evidence that has specifically addressed this question since that time. Here we have a much larger number of trials, some of them are bigger, and we looked at the benefits of oral nutritional supplementation in older people at risk from malnutrition from any condition. So not just hip fracture, but also stroke and people admitted acutely to hospital with a wide range of medical conditions. And here we see that the evidence suggests that there is also a reduced risk of complications in older people from supplementation. What about the compliance with oral nutritional supplementations? In my Cochrane review, the trials that presented data such as this showed that compliance was around 50 to 75%. And in a systematic review looking at compliance with oral nutritional supplementations more generally, then compliance in hospital was around 2/3, somewhat better in the community at around 80%. But most of these studies were around only 12 weeks long, and longer term compliance over months is certainly an issue with these supplements. More generally, we know that all nutritional supplements are associated with some decrease in appetite, but overall the energy and protein intake is increased by their use. They're best given between meals, so they have less effect on suppressing appetite, and it's better to give a little and often. Even in the most compliant population group, we would only expect a weight gain from their use of around about 1 kilo, so actually a relatively small weight gain. And in fact, the message really is with a lot of these interventions that just oral nutritional supplementation is not the complete answer. We need a multidisciplinary approach to improving nutrition in this population. Some of the questions that the Cochrane review really doesn't answer. We have small, poor quality trials. Almost all the trials included people at the very highest risk for malnutrition, particularly people with dementia. And we know that dementia is a common issue in people who've had hip fracture. The outcomes are rarely patient-reported outcomes, and therefore actually there's hardly any information about quality of life in these patient populations, which given the age of the population is probably the most important question. And one has to ask really whether these medical outcomes such as mortality, length of stay, actually are they relevant? Is not providing nutrition support to older people not an ethical issue that we should actually make sure that we provide adequate nutrition to older people irrespective of outcome? And should the focus of nutrition support be really on identifying those at risk of undernutrition to avoid the consequences before even people who have fracture? A couple of things that I found whilst I was updating my search for this talk. I thought this was an interesting systematic review of geriatric team rehabilitation after hip fracture, a meta-analysis of randomized controlled trials. There were 7 randomized trials of geriatric team rehabilitation, and this is the table from that systematic review. It's very small, you won't be able to read it, but highlighted in yellow is the information provided by those trials on nutrition as part of geriatric team rehabilitation. 6 of those trials provided no nutrition information at all, making one wonder whether nutrition was ever part of their strategy for rehabilitation. And the final one provided information saying that there was provision of a protein drink, but no other information, no other multidisciplinary approach to improving nutrition support in this group. Finally, I leave you with a paper which came out recently on the question of trials in the geriatric hip fracture population. And I think the title says it all. Trials are rare and they're underpowered. A systematic review and a call for greater collaboration. Okay, thank you for listening to my talk. I'm going to unshare my slides.
So many thanks for that fascinating talk, Alison. Really interesting to see the extent of the evidence and also to talk through the limitations of them and what the implications are for incorporating the findings into clinical practice. We're going to move on to Dr. Christine Baldwin now, who is from King's College London. So Christine's research focuses on nutritional management of malnutrition, systematic review methodology, and the use of evidence-based medicine in clinical practice. So she's the author of numerous reviews in the field, including 2 in the Cochrane Library. So we'll pass you over to Christine now, who's going to share her slides, and I'm really looking forward to your talk.
Katie, I'm hoping that my slides are already showing.
I can't see them. Yes, I can see them now. Perfect.
See them, and you can obviously hear me.
Yes.
Okay. Yeah. Okay. So Alison has introduced 2 different types of nutritional interventions, and she's talked about the evidence for their use and highlighted some of the limitations of the evidence base. What I'm going to do now is broaden out the list of oral nutritional interventions available, and then take a critical look at both the evidence base and issues raised by their use in practice. So oral nutritional supplements are sitting there over on one side. I'm not going to add anything more to what Alison's already said. We've already considered those in detail, but I want to focus on the other 3 circles. So dietary counselling is the term most usually used in practice to describe food-based options. And the reason for this is that if we want people to eat more food, then we need to give them instruction or advice around how they might achieve that. Food fortification is a strategy often considered as part of the portfolio of interventions provided through dietary counselling. And then there's this final grouping, supportive interventions, which is a term used to describe interventions most usually used in an organisational setting that are designed to influence the nutritional status of groups of people. So examples of supportive interventions would be something like providing food assistance at a ward-based level or a protected mealtime initiative. The other thing that it's important to say about this group of interventions is that they're not all distinct from one another, and they can be used indeed frequently are used in combination. And so you might get somebody who's having dietary counselling, but they're also having an oral nutritional supplement as part of that. So looking first at the evidence for dietary counselling or dietary advice, which are the food-based approaches. Like Alison, I've been involved in producing Cochrane systematic reviews over the last 20 years. And I have conducted a systematic review looking at the effect of dietary advice on a range of outcomes. So what I'm showing here, so the review has included randomized controlled trials in patients from a variety of clinical backgrounds. So this isn't a review that was focused on looking at patients who have had a hip fracture. And they're all patients who are at nutritional risk. And the trials, what the trials had in common is that they're all looking at dietary counselling interventions compared with routine care. So what I'm showing you here is the meta-analysis for weight change. We identified 12 studies that looked at dietary advice compared with routine care, and there were data from 9 of those studies on weight change, and that's what you can see here. And the data are subgrouped, or the studies are subgrouped according to the length of intervention. Overall, the overall effect, which you can see by the diamond down at the bottom, suggests that there's a small benefit to weight from receiving a dietary counselling or dietary advice-based intervention. But there's high heterogeneity in these analyses, suggesting that the studies are not really similar enough to be combined. And again, I want to highlight the very small number of participants in these studies. So only 733 participants divided across 9 trials. I also have the results for the effects on mortality. So same group of 12 studies, but this time 10 studies provided data on mortality. And the overall effect suggests that there was no difference between groups in mortality. At this time, we have low heterogeneity or no heterogeneity between the findings, but again, very small numbers of participants and few data on other outcomes. But what I hope you've also noticed, if you're looking at these slides, is over on the right-hand side, this is quite an old review now. And one of the things that you sign up to when you get involved in Cochrane reviews is updating them on a regular basis. And we're very close to publishing the results of the updated review. So I'm going to just share the findings with you now. So this version of the review is still in review and isn't published, but we have now been able to include 24 studies with nearly 3,500 participants in the analyses. Most of the studies are in older people who are frail and undernourished. They come once again from a variety of clinical backgrounds, and there is only one of the 24 studies that's a study in people at risk of fractures. And the findings are remarkably similar to the earlier version of the review. So still no difference in mortality, small effect of dietary counselling interventions on weight, no effect on hospitalisations or complications, and a short-term improvement in global quality of life. But the thing I really want to draw your attention to is the low quality of evidence, which is a really important point. And it means that we're very uncertain about these estimates. So if I move on now to the other intervention category and consider the evidence for supportive interventions. So I gave you an indication of what these were right at the start, but just to remind you, they're actions taken by someone else and often happening at an institutional level. So we don't require participants or patients to understand and act on interventions in the way that we do with dietary counselling. I have led a team that worked on a Cochrane review on this topic. And before I start talking about the results, I just want to describe in more detail the sorts of interventions and the ways that we categorise them for this review. So looking at the first line, the first grouping we had were changes made at an organisational level. And in that grouping, we put studies of things like providing assistance at meal times, red trays, protected mealtime, or staff training interventions. Second categorisation, modifications to meals or to meal patterns. And so you can see examples of things like food fortification, but maybe at a ward level, or even possibly across a whole residential care home. Or again, modification of meal patterns from the usual 3 meals a day to maybe 5 small meals. Changes to the feeding environment were the third category, so introduction of family style meals in a dining room or improvements to the ambience of the dining room. Additional supplementation of meals were the fourth category. And so these were strategies like provision of oral nutritional supplements, but in very small volume. So often it's 50 mils at a time as part of the drug round. So again, it's an institutional strategy as opposed to patients at home having to remember to take the supplement. And the final grouping was home delivered meals. So for this review, we identified 41 randomized controlled trials. They were all in older people, 15 of them in a hospital setting, but you can see the types of setting shown here. Only 1 in an acute hip fracture unit and 1 on an orthopedic ward. And just over half of them in residential care and a small number happening in the community. And you can see how from the table, the number of studies that we found for each of those groupings that I've just described. So what effect did they have? So looking again at effects on weight change. So now you can see the overall meta-analysis, and you can see instead of subgroupings according to time, I'm showing you subgroupings according to the type of intervention, so the 5 categories that I described. So overall, with data from 17 of 41 studies on weight, we were able to describe a small but significant benefit to weight from receiving a supportive intervention, and that effect was also apparent in 3 of the subgroups, so modifications to meals, supplementation of meals, and in the home delivered meal group. Looking at the results for mortality, again overall we saw a significant reduction in mortality in groups receiving supportive interventions, and that effect was also seen in the grouping changes to organisation of nutritional care. There was no heterogeneity either overall in analyses or between subgroups. And looking at data on other outcomes that we looked at in the trial, again, very little additional evidence of an effect, a small improvement in number of days of hospitalisation, but once again, for many outcomes, very low quality evidence. Few trials reporting adverse events, just one that highlighted that up to 28% of patients stopped taking the oral nutritional supplements because of intolerance, dislike, or refusal. Overall, these are small studies, they're underpowered, And the other really important thing to point out is, although just over half of the studies happened in a residential care setting, the meta-analyses are dominated by trials from a hospital setting. And so it's difficult to know whether the results seen would be generalizable to all settings. And so what I want to do now, having looked at the evidence for a range of different interventions and highlighted the limitations, I want, for the final part of this presentation, to really consider options for taking a more patient-centred and problem-centred approach. So you've already seen this slide. And Alison highlighted that malnutrition is a complex condition, and it often occurs within very complicated care systems. And one of the particular difficulties for patients sitting in the middle of all of this is the loss of autonomy in relation to food, with an associated impact on quality of life. Again, you've already seen this slide, and I simply want to use it to highlight the importance of nutritional interventions not only being individualised, but also being targeted at the cause, while keeping the patient needs at the centre. And so I want to share details of a small but ambitious study from a Danish group, where they sought to examine the feasibility of involving older adults in interventions that were targeted at the cause of malnutrition, rather than simply providing a solution with the patient as a passive recipient of the solution. So this was a cluster randomized trial, and it was conducted in people living at home. A two-stage intervention. So the first part of the intervention involved training of healthcare staff. And can I emphasize healthcare staff, not just dietitians, but other people who were coming into contact with these patients. And the healthcare staff were trained to be able to assess functional ability in relation to meals. Following the assessment, there was a collaborative, evidence-based goal-setting approach used to actually plan intervention strategies that targeted the problem. Now, I'm not going to go through the whole list in the middle box on that slide, but maybe just take one example. So if malnutrition is resulting from some sort of difficulties with mental health, maybe leading to lack of interest in eating or loneliness, then surely the solution is to actually address that and make the intervention centered around the social aspects of eating. So optimizing opportunities to eat with others, that may be family members, maybe volunteers who can eat with somebody, or using buddy systems, or indeed maybe even using lunch clubs external to a patient's home. The early results suggested that it was feasible to deliver this intervention, but the trial, of course, being a feasibility study, was too small to tell us much about the other outcomes, but they did show a significant improvement in quality of life. For the last study I want to stay with the theme of individualised interventions. So this is a large recent randomised controlled trial known as the EFFORT trial. It was conducted in hospitalised patients. And there are two aspects that I want to highlight about this trial. Firstly, that there was a protocol-driven process for identifying and managing patients who were undernourished. And secondly, that the intervention was individualised. So it wasn't a one-off intervention, but they went to great lengths to individualise it to patient need. Two key findings: significant reduction in all adverse clinical outcomes, so all clinical outcomes combined, and significant reduction in all-cause mortality. Now, this study has just reported their 6-month follow-up. The paper is still in press, and I'm showing you the reference there. And unfortunately, the significant findings they found on during hospitalisation have not been maintained to 6 months in the community. So after 6 months, no difference between groups in mortality and similar rates of rehospitalisation or falls. And what this really highlights is the lack of a legacy effect of this intervention. And surely what that's resulting from is failure to manage the nutritional intervention across boundaries of the healthcare system, and probably a lack of the monitoring, review and support needed to maintain the nutritional intervention. So I've talked about a wide range of evidence, and I've talked about where that evidence is lacking. So maybe just finally to reflect on the problems of researching nutritional support interventions. Evidence is frequently limited. There are often ethical issues when designing trials. Ethics committees don't like no intervention groups in vulnerable, malnourished older people. It's very difficult to assess compliance, and because compliance is difficult to assess, we often don't know how much contamination has occurred between groups. It's also difficult or almost impossible to blind interventions. And so again, patients in the no intervention group can quite easily adopt strategies associated with the intervention. And these trials are quite difficult to get funding for. And so to conclude, I don't think that I've presented evidence that these interventions don't work. I think what we have here is insufficient evidence to know whether there is an effect. Again, I agree with Alison. Ethically, do we need evidence? And if we are going to agree that we should intervene in these groups of patients, then we need adequate systems for recognition of patients at an early stage. And healthcare professionals other than dietitians need to be able to provide first-line, simple nutritional interventions in all healthcare settings. Thank you.
Many thanks, Christine, for a really fascinating talk, and I suppose lots of questions coming to my mind as a result of some of the studies that you've highlighted, and so thank you. Just to remind people and latecomers, if you have questions for any of our speakers, we're going to have a question and answer session after the final talk, and please do feel free to type in your question into the question and answer bar at the right hand side of your screen. And if there's a question that's already been asked that you would particularly like to see an answer to, give that question a thumbs up, and we will answer the questions with the most thumbs up first in the Q&A session. So without further ado, I'm going to delighted to introduce our final speaker. So we have Miss Misar Dubas, who's currently a final year of her PhD, which explores the nutritional management of nutritionally vulnerable older adults in the community, specifically within falls prevention services. So we'll bring up Misar, and looking forward to your talk.
Thank you very much, Katie, and thank you for the opportunity to speak at the session today. In my session, I'm going to pick up on what Christine had just left off with and talk more about the opportunities to integrate nutritional care among other multidisciplinary professions, and this will be highlighted by the data from my PhD research. So as Christine mentioned, one of the key things we need to be able to do is to identify and recognize those at nutritional risk of malnutrition to be able to effectively treat those and provide effective interventions. So I want to draw your attention here to the nutritional care pathway. And this is the pathway for nutritional management that's used by the dietetic profession. I'm highlighting the one used within the British Dietetic Association here in the UK. However, this is universal across different dietetic bodies as well. And the first step of this pathway is of those at risk and identifying those at a nutritional need. And this is primarily a non-dietetic task that can be performed. And then based on results from the identification or screening, then onward referral can be conducted to a dietetic specialist for continuing the steps of the pathway, so assessment, planning, and providing an intervention. Additionally, there are several clinical guidance among nutritional bodies that recommend identification and documentation and integrating nutrition within multidisciplinary teams across the UK, European guidance, and American guidance that I've highlighted here in the table. Additionally, as well, there are clinical guidance specifically related to falls management and prevention and hip fracture management that also recommend nutrition integration within multidisciplinary teams. Now, the next thing I want to point out is the challenge that we have, that once we identify all those who are at a nutritional risk, will dietitians be able to effectively see all of these patients and manage all of these patients given the staffing challenges and shortages within this workforce? I've highlighted some data here within the UK and Australia, which is statistics of the workforce data among the different professions. As you can see that there is a relatively lower number of dietitians compared to other allied healthcare professions, as well as nurses and physicians, and similar results are also seen across Australia and Europe. So this overall raises the question on being able, how we can effectively manage and see all of these patients at nutritional risk, and how we can utilize the key healthcare contact opportunities that this older vulnerable population may have for simple frontline management of nutrition, which was also highlighted in the previous session. So within practice, this also raises a question on how, within practice, this raises the questions on, are those who are of nutritional risk being identified by different professions within the healthcare settings throughout their journey during a healthcare visit. And this led to the development of my first study, which is to identify those at nutritional risk and the documented nutritional care of older people recruited from different community settings within South London in the UK. And this was an exploratory setting that was based on a subset of a larger cohort study, which was the NutriCom study. And this study looked at recruited participants from 4 different settings and assessed their nutritional risk status, as well as other patient outcomes. So for those who consented to use their electronic healthcare records, we looked at a subset from two of these settings over a 1-year period and mapped their participant contact with the different hospital departments and staff that they may have, as well as their documented nutritional care. So to be able to consider the contacts these people may have, these people may have, and if they were being recognized across their journey. So the baseline characteristics gives us an idea of these patients, as well as the distinction between the 2 groups that we looked at. So if we look at the intermediate care group, this is a group that was receiving community health care services. And this group is relatively more frail. As you can see, a higher proportion are at risk of, are more frail with a score greater than 4, as well as have more comorbidities and are older. Among the general practice group, they don't receive any extra healthcare, community health services other than when they go see their GP, and they can be considered relatively fit as compared to the intermediate care group. There's a lower proportion with frailty and comorbidities. But I do want to highlight here, if when we assess those at baseline who were at nutritional risk, so they were either had an underweight BMI less than 20 or were having weight loss in the previous few months, there was a proportion that we assessed for the study that were at risk. So 67% of the intermediate care were at nutritional risk, and 15% of the general practice population were at nutritional risk. So this is where we wanted to look at the health record data to see if they were also being identified during a healthcare visit by other healthcare professions. So in this slide, we can see the the numerous healthcare contacts that the nutrition risk population has with healthcare facilities and healthcare professions. If we look at the healthcare visits, most of these participants were seen in the outpatient setting in both groups, and specifically in the intermediate care group, they were seen mostly at an inpatient setting, given that they were more frail. And they do have, in both groups, there is relatively a high contact with healthcare professionals, such as physicians, nurses, and other allied professions, as you can see here. And the admission reasons, the top 4 reasons are listed in this table. And we can see in the intermediate care, the reasons differ slightly. They are admitted for respiratory exacerbations, falls due to having a higher risk of falls, and for mobility, such as therapy and balance. This was also seen among the general practice cohort. Now, among these numerous contacts that we just saw among the nutritional risk group, we wanted to see, again, were they identified during any of these visits among any of these healthcare professionals. So if we look at the first row here, so this is the intermediate care group, and that, as mentioned, we assessed them for the research that 67% were at nutritional risk. However, within the hospital, only 28 were screened and identified at nutritional risk. 21 in the hospital were ended up being referred to a dietitian, and even less were seen by a dietitian across the different healthcare settings. And this was even less within the general practice cohort. So if you can see here, 15 were identified by us for the research. However, only 2 were screened and only 1 was seen in the outpatient setting in the end by a dietitian. So this highlights that despite the differences between the groups, where the intermediate care group was receiving community healthcare services, that nutritional risk was undetected in both groups across the different settings. So this highlights missed opportunities for identifying and ultimately managing the vulnerable people at nutritional among different visits and among the different teams that they come in contact with. So therefore, this calls for improved strategies for detecting and managing malnutrition within the community, and more specifically to rethink the role of frontline management, simple frontline management that can be done by non-dietetic healthcare professionals, given the key contacts that this population may have. So this led to the development of my next study within my PhD research, which was a co-design study of nutrition intervention strategies within falls prevention services among patients and staff. So just to give a little bit of background around falls prevention services, which may be known by many. So these services are multidisciplinary services where it's a key contact for a lot of older population at risk of falls, and for the management of their falls and prevention and management of related injuries such as fractures as well. However, there is limited evidence on the role of nutrition within these services, specifically here in the UK. So before we moved on to co-designing my study, we first conducted a survey within the UK on the nutritional care practices within falls services, and this was circulated across, and we had responses from 63 falls services. So most of those who responded were physiotherapists. So among those who responded, 33% had a dietitian involved within their falls service, and 2 had a dietitian directly part of their service. The remaining were referred onward to an outsourced dietetic service, and only 10% had a written nutritional care policy. And then when we look at nutritional screening within these services, among the 39 who answered, 35 services do conduct nutritional screening at first visit. However, this seems to be a one-off practice, where during subsequent visits it was much less services conducting this. And most of the nutritional screening that was performed was done by physiotherapists, occupational therapists, and nurses, which is not surprising as they make up majority of this the falls services as a professions, as well as it is a non-dietetic task to be performed. So putting all of this, as well as looking at the literature first, there is an association between the risk of malnutrition and the risk of falls highlighted by systematic reviews, as well as there is a role for nutritional interventions within multi-component interventions for the prevention of falls as well. So then putting all of this together, we continued into the co-design study. And before we're able to overall design and tailor a strategy within the service, we first want to understand the context of nutritional care within the service. So this was done by observing the service that was selected for this for the study and interviewing healthcare professionals, which were multidisciplinary professionals, and patients within the service, and just understanding the nutritional practice that is already being done, understanding the perceptions and experiences among both the professionals and the patients in terms of nutritional care, as well as understanding any gaps and the needs nutritionally among the professionals and the patients within our study. And then using this data, we can then tailor interventions using the co-design workshops. So among the different themes that came out from both the healthcare professionals' experiences and the patients' experiences, I just want to highlight one main theme that was brought out by the healthcare professionals, where nutrition seemed to be everyone's business but nobody's job, which is quite an interesting take, where there were mixed a lot of themes that came out, which discussed that nutrition was conducted, for some activity was conducted. However, the continuity was much less, and similar, there was barriers to consider around the awareness of nutrition and prioritizing nutritional care within the role of the professionals. And as well as it was identified that the healthcare professionals within the service do represent a key contact for identification. However, the lack of continuity as well was mentioned. And this is an ongoing study, so I have not yet conducted the workshops to be able to give a recommendation of one strategy within the service. However, I do want to conclude here that a few of the strategies that were discussed with the healthcare professionals that came out of their interviews of what may be needed within this services. So again, this to summarize the main point of where and how can we integrate nutritional care among the different healthcare professions and among the different key contacts that these older vulnerable populations come into contact during their healthcare visits. So I do want to now just hand it back over to Alison to finalize and go over the questions for discussions altogether. Thank you.
Thank you. Thank you, Masar. I'll just, we as a result of our talks, we formulated some questions which are very sort of generic questions, which are things that are very complicated, although the questions are apparently simple. So the first question is really, do we need better evidence before action to improve nutritional intake in older people before or after hip fracture? Do we actually need a better evidence base? And if we do, what is that evidence base that we should develop? Is it actually demonstrating that nutrition improves outcomes? Is it, how do we better implement nutritional intervention? So an implementation study rather than actually an ordinary randomized controlled trial. And secondly, where can we take action? Actually, is this a much broader theme that we need to take action in older high-risk populations, particularly falls clinics, if we're talking about fracture prevention? And should we do that as well as after fractures? And I think most importantly, whose responsibility should this be? My feeling is everybody's responsibility, but someone needs to take responsibility to take the initiative to coordinate what we should do about this. Okay, I'll end there and I'll hand back to Katie.
Great. Thank you, everybody, for really stimulating talks. And I can see that we have a couple of questions in our Q&A panel on the right-hand side of your screen. For attendees, if you have additional questions, please feel free to type them in, and they can be entered anonymously, or you can disclose your name. And if there's a particular question you'd like to see answered, please give it a thumbs up, because that's how we will order asking the questions. So the first question is from Morten in Denmark, and Morten's asking about your experience with nutritional supplement drinks. So from experience, people find it difficult to drink them due to nausea. Any recommendations on particular products or alternatives that have proven more feasible or perhaps boosted adherence? So I'm not sure who'd like to take this question.
I'll kick off, and then I suspect Christine can contribute something too. Yeah, I mean, when we were doing our nutrition team ward rounds, it's a perpetual issue that some of the oral nutritional supplements, some people just really don't like them. And actually for us, it's a hospital issue because we are tied to one manufacturer and the dietitians aren't allowed to buy products from another manufacturer. So that really limits the choice that's available. And if it turns out that people don't like oral nutritional supplements, the first question one should be asking is actually, is your entire thrust of your intervention based on this? And really you should be thinking more widely, but also how the hospital catering and kitchens can help to produce products themselves, which actually may counter these problems. So we're talking about drinks, milk drinks that the nurses could prepare on the wards, or actually fortifying existing food that would help with these issues. One of the, I think, most interesting studies, which I think has been conducted, which is part of Christine's review, is looking at the use of oral nutritional supplements provided a little and often. Often what happens is people get a supplement bottle plonked on their bedside cabinet or on their tray, and they just get left to get on with it. And they're often better cold, and so these things warm up and people don't like them. So one of the most important trials in this area, I think, was by a geriatrician in Glasgow. And what they did was they actually gave the supplements in the medicine cups for people to swallow their tablets on the medicine round. Okay, and so actually you were just giving people a little and often, and so it was just given to people as part of routine care, and that way people were quite willing to take a little often. They didn't have to sit and drink one bottle at a time, and actually the compliance was very good with that kind of intervention. So that's one way of looking at it, but I think one needs to accept that actually these supplement drinks have issues, and certainly in the long term it's very hard for people to continue taking them over more than a few weeks because they're tired, they need variety, and they actually can often taste really quite sickly sweet and not something people would want to persist with.
Alison, I don't want to add a lot to what you've said. You've really covered that very nicely, but just to remember that nutritional interventions need to be individualized to the patient at the start, but secondly, that we need to monitor and review and look at all the other sorts of strategies that Alison's just suggested. Nutritional supplements are a very valuable part of the overall oral nutritional intervention toolkit, but they're not the only thing in there. And we may start with them, but we need to review and monitor in order to know whether they've worked, what are the issues with them being taken, have they, as Alison just described, been left on a bedside cabinet. When you go and see patients, you so often see these things festering away in very hot wards. So think more broadly. We've tried to get you to maybe sort of consider the full range of items in the toolkit and remember the importance of review and monitoring.
Okay, fantastic. So we've got a fair few more questions kind of coming through in the feed now. So the next question that's the most popular is whether there's experience for using albumin levels as a measure to, and monitor the protein level. So I guess using it as an outcome or as a response to nutritional intervention. So Alison, I see that you're leaning forward. You have to take this one.
I have to say, as a clinical biochemist, this is a source of great frustration to us. Many of the studies that have been done looking at prediction of poor outcomes after hip fracture have used serum albumin. That's fine. It's a good predictor. But serum albumin is not a predictor of nutritional status, okay? It is not. It is what we call an acute phase protein. It goes down rapidly as soon as somebody has a major injury, inflammation, any chronic illness that causes inflammation. Albumin will go down. You only have to operate on somebody and the albumin will go down within a day or two. So it is not an indicator to intervene except in exceptional circumstances, okay? It is not a marker of nutritional status. It's much better to look at your patient and to make an assessment, if you can't weigh them, of what you think their weight might be and their BMI might be, then to actually, and to take a history about what they've been doing, or a history from somebody else if you have an older person who can't provide that history. So albumin is not, and in the nutrition team, we never intervene on the basis of a serum albumin. And if we get someone who refers us a patient because of their low albumin, I'm afraid we lose our cool.
Okay, very strong words there, Alison. We will move on to the next question, which is from Emer. With its emerging evidence, where does sarcopenia identification and management come into all of this? So just a note that it hadn't been mentioned across the studies. So I'm not sure who would like to jump on that question.
Christine, you want to do that, or shall I do that?
I actually think you may be better, Alison, but I've just been looking at that question as I was also listening to you talk about albumin and actually wondering if that's a webinar in its own right. I think that we have really dealt with the very basic level. We're talking about getting the identification and the first line management right. And I fully accept sarcopenia is an issue and is going to contribute to frailty, but it's a big topic and the nutritional intervention in relation to sarcopenia is quite specialised. Do you want to add to that, Alison?
Yeah, I mean, I'm presuming people know what we mean by sarcopenia, which is basically a relative deficit in muscle mass, okay, which is a very good predictor of frailty and therefore falls and fractures. What we don't have, and I work on a frailty trial, okay, so we are looking into this issue. First of all, we do not have a good, easy way that people in clinical practice can identify sarcopenia. So if you want a screening test that actually you do something about, we don't have that. There are all sorts of fancy methods of scoring sarcopenia. They have very poor predictive ability at the moment. So we're really in our infancy about being able to identify who we should intervene with, how we assess them. And then in terms of interventions, actually whether we have good interventions which we use to combat this. And I would argue that for this patient population we're talking about, particularly hip fracture patients, there's huge overlap between the two. And actually, to some extent, it's almost a wild goose chase to go along the line of looking for sarcopenia in addition. Actually, we have something that we can readily look at, which is a history of weight loss, people's weight and body mass index, and really we should be acting on that. Sorry, all those sarcopenia researchers who may be listening.
Just noticed the attendees numbers have dropped significantly. I'm only joking. Okay, so the next question that we have is from Barrett. So very interesting webinar, thank you. Have a question regarding the evidence between pre-operative malnutrition and post-operative delirium. In what point is research moving in that area, and is there a correlation between malnutrition and delirium?
Okay, I'll tackle this one. I have to say, I have looked into this area a couple of years back, wondering if there was potential to do a trial looking at how one might intervene to prevent delirium post-operatively in older people. I think an awful lot of the things that can be done relate to things that probably don't relate to nutrition at all, in things like fluid and electrolyte balance, correcting actual abnormalities in people's blood, prompt dealing with the fracture, preoperative care, anaesthetics, all these sort of things. And some of these things we can't do much about because people are frail and they need to have their operation. One thing I've wondered about, but I haven't seen any evidence to support it, is whether actually there's increasing push to try not to fast people for too long before they have their surgery. We're not talking necessarily about hip fracture, and also giving loading carbohydrate drinks in people that may help them to recover more quickly from an operation, particularly in an older person, where obviously you want to maintain cognitive function, you don't want to fast them too long. Potentially that might be an area which would be interesting to explore, but I actually know of no evidence in this group to show that an acute intervention in terms of nutrition would actually reduce the risk of post-operative delirium.
Thank you very much for that. So we'll move on to the next question, which kind of suggests that if the cause of malnutrition is multifactorial, then the intervention needs to be multifactorial too. So the author of this comment is suggesting that we need to move away from pinning our hopes on a single intervention like oral nutritional supplements, and expecting to intervene on one particular intervention and change outcomes within a 1 to 2 week hip fracture stay mightn't be so easy. I guess, does anybody have would like to feed into that? Perhaps Christine, because you talked about kind of different interventions across settings and needing to think about the bigger picture. Maybe that's something for you to comment on.
Yeah, I think you very much summarised the questions that we raised. Unfortunately, we don't have answers to those questions. So yes, malnutrition is multifactorial, and unfortunately we often see patients as these sort of passive recipients where we just think there's one thing that we can give them. I think we need to broaden our understanding of the range of options available, consider using all of them, and I think the question also highlighted the length of time people often stay in hospital. We're focusing so much on hospital, but actually maybe what the EFFORT trial has really highlighted is that if we don't maintain these initiatives when patients go home, then we're not going to sustain any benefits gained in hospital. So length of stay is very short, but of course the majority of malnourished patients are in the community, and it's probably in the community where we need to be focusing our efforts. You get many fewer dietitians in the community, and I think the sorts of initiatives Masar was talking about are really important in terms of actually identifying ways of working with community staff.
Okay, and I think that actually ties in quite nicely with the next comment or suggestion is, you know, engaging with other staff, and perhaps for, I wouldn't say simpler, but nutritional interventions such as providing drinks or nutritional supplements, that maybe this could be completed by other disciplines, and then dietitians could focus on kind of a more coordinated systems approach and seeing genuinely complex patients across the care continuum. So that's kind of a suggestion posed by Jack. I'm not sure whether or not you think that maybe engaging the whole team to support, I suppose maybe in inverted commas, easier nutritional interventions, and then allowing dietitians to focus on the more complex patients is a positive way forward.
And I think what you're describing actually in that question is what's happening in an awful lot of UK hospitals. And so we have this role of the dietetic assistant, and the dietetic assistant might be seeing the less complex patients. But again, looking at that question, we're still focusing on that very short period of time that people spend in hospital. And I personally think that the most important aspect, or the most important thing we can achieve when somebody's admitted to hospital, is that we recognise that there's a problem and we come up with longer term strategies for managing that, in particular for when they go home. And so maybe the energy should be focused on managing the boundary of healthcare and making sure that things are continued, and that we're not just saying, oh, do you like a strawberry drink or a chocolate drink when you're in hospital, job done, but actually thinking, how is this going to work in the longer term? Would compliance would people comply for 6 months or 12 months with an oral nutritional supplement, or do we need other strategies? And then we need to go back to, what's the cause of the problem? Why is this patient becoming malnourished? Have they simply lost interest in eating because they're lonely? And can we address that? And there are some lovely facilities available, but so often we just don't consider them. And so actually maybe the people who are working at a more specialist level can be starting to sort of develop more complex ways of working with patients, so that we address all of these questions, both in hospital and at home.
Fantastic, thank you. So time for a few more questions. So this one is directed specifically at Masar. So the anonymous person has asked, just wondering, for your qualitative interviews, do you have feedback of what sort of nutritional support that they need within the patient population?
Yeah, I think this, sorry, make sure I'm not muted. Yeah, so this ties back to the falls prevention services in the population that are referred here. And again, a lot of them are at risk of undernutrition. So a lot of the support needed come back to what was discussed in the sessions by Christine and Alison on the types of interventions that may be needed. But additionally, that came out of these interviews from a patient side briefly was also the need for knowledge around nutrition and some behavior change of recognizing you're losing weight and recognizing the eating habits, and this is where we focus on the need to pick this up during a visit, where if it's not recognized by the patient, someone picks it up during a healthcare contact. And additionally, what I wanted to add to the previous comment on having, again, I'm talking a lot about the non-dietetic approach of for simple frontline management. So this was also reviewed. We're conducting a systematic review as well of non-dietetic interventions and seeing what there is out there in the literature of some interventions that are being done and their efficacy as well on patient outcomes. We do have one review that came out on the efficacy of volunteers as well, and helping deliver interventions both in hospital and in the community settings. So that's something definitely to think about.
Great. Yeah, I think that this the idea of promoting that it's everybody's responsibility to capitalise on opportunities is really important. So we have another entry in Anonymous which actually has several questions. So in the interest of time, I'll just go for the first one. So really interesting that oral nutritional supplement compliance was better in hospital than the community. Would expect the opposite. Can you offer a reason why? So I think that relates to Alison's presentation.
Yeah, I mean, it may just be that these are different patient populations, and so the hospital patients, there's somebody watching over the patients, and they are also there for a comparatively short period of time as well. And compliance definitely wanes over time, and the community interventions are generally much longer. So the compliance will decrease over time because these are longer interventions, and also because there's much less support around in a hospital ward. Okay, it may be difficult for people to encourage people to finish their supplements, but there are people there. In an old person who's living alone, they don't have that support for helping them with their compliance. And also, you know, there are issues with actually how you deliver these supplements, keeping them cold, making them nice. So the hospital setting is better set up for that sort of thing as well. I don't know if Christine's got things she would like to add too.
I think not specifically, Alison. I think you're right. Actually, people often eat better in hospital, and they're probably more likely to take supplements in hospital. And it's not surprising over time that people get less interested in them. You know, we probably all would if we ate the same food day after day after day. But yeah, nothing more beyond that.
Okay, so I think we've got three queries left. I think one is maybe a quick response, so we'll ask that one first. So would Dr. Baldwin mind repeating the results of the effect of supportive intervention on mortality results? I don't know if you have it to hand, Christine, but maybe I can ask it.
I have it here,
Great.
because again, I can see the questions, which is great. So what I said when I showed that plot, remembering that there were 5 different types of supportive intervention shown within that meta-analysis, there was a small but statistically significant reduction in mortality in the groups that received supportive interventions overall. But that number came from adding together the results across all of the different interventions. The only individual group for which the result was statistically significant was for the group that received changes to organisational care. And actually within that group are the 2 trials on hip fracture patients. So actually, maybe we have a little indication of a possible way to intervene. So these are using things like dietetic assistance, and they're using protocols. So a bit like the EFFORT trial, protocoled management of nutrition care. So much nutritional care is ad hoc. It's not actually driven by a protocol. And so actually saying we will screen everybody as they come in, and the actions in relation to that screening will be, and actually setting that out and making it operate as a hospital policy. And I'd add a tiny plea in there for having one for the point of discharge as well. I hope that's helped.
Great, thank you, Christine. So the last 2 questions, I'm going to summarise them as a comment, just in the interest of time. We're coming up to a close, and I think both of them are pointing to the need for well-designed and well-powered interventions that we can get more definitive answers from the evidence. And in particular, Janik is highlighting that the products that are used in different trials have different amounts of energy, protein, vitamin D, etc. So whether or not we can do some subgroup analysis in future trials that are better powered in order to kind of refine down what's needed in terms of nutritional interventions. But I'm going to wrap up the Q&A part of the seminar in the interest of time. I want to, if we can move, I'm not sure, James, if you can move on to show my last slide. But basically just want to reiterate the thanks to the fantastic speakers today, and for all in a really fruitful discussion at the end of the session. Really delighted to see such great engagement. Before closing the webinar, I just first want to invite all attendees to join the special interest group to find out about future free webinars that we'll be offering via the membership portal. And then second, just to close, I'd like to introduce Jack Bell, who's an advanced dietitian and conjoint principal research fellow from the University of Queensland, who'd like to highlight some Fragility Fracture Network initiatives and free resources that are independent of the current talk, which members may wish to avail of.
Yeah, hi, it's Jack here. Can you hear me okay?
Yeah, I can hear you fine. If you'd like to share your, yep, and we can see your screen now if you want to go to slideshow view.
Right, okay, I'll just, hang on. I've got something exactly in the road here. Okay, so I might actually just share off this because it's, okay, here we go. So thanks so much for the quick opportunity to just show what we've been doing across more broadly in the Fragility Fracture Network in nutrition care. We've got an education, as part of the education committee, we've got a nutrition advisory board, and I'll just give a brief update on that. I guess the things that we've done since we've established the board, the first one is I'm most interested in today's presentation. It was fantastic. What we've been focusing on is nutrition care of the older patient with fragility fracture, using systematized interdisciplinary approaches across acute care, rehabilitation and secondary prevention settings. And so that's a chapter that we put in the Ortho Geriatric second edition. There's a link there if you'd like to do a screen dump and take a picture of that. Alternatively, we can provide the slides later. We've also presented a number of presentations and workshops around what we call simple nutrition care or systematized interdisciplinary malnutrition program for implementation and evaluation. It's actually complex, but it's all about getting interdisciplinary teams on board across the continuum of care. And we're also currently progressing a multidisciplinary nutrition management of nutrition care in older adults, an evidence-based practical guide for nurses, and that will also be a textbook. We've got 21 chapters lined up with some great authors that we'll be aiming to release in autumn 2021. And again, it's really showing how we can get champions who are well placed across the continuum of care to really lead the charge, both in terms of not only doing hands-on nutrition support, but also, especially in the absence of dietitians or limited resources, they are often well placed to actually lead processes to champion nutrition care as well. So keep an eye out for that. That'll be coming out soon. And I think that will be my time done. Thanks so much for the opportunity to share.
Many thanks, Jack, and thanks for keeping to time. So with that, we're at the hour and a half again, and just a huge thank you to all of our speakers. For really fantastic input. Delighted with the first webinar coming to a close. I wish you all a very happy Christmas, and with that we'll complete the session. Thanks everybody.